Good afternoon and welcome to the OR Today webinar series. We're excited to have over 320 registered attendees for today's webinar. I want to remind you today's webinar is eligible for one continuing education hour. The post-webinar survey and certificate process are now automated, so the survey link will be included in the follow-up email, which you'll receive about an hour after this webinar has finished. Once you've completed the survey, you'll be able to download your certificate immediately, and one lucky attendee will win an Amazon gift card for completing the survey. Okay, let's kick off today's webinar by giving an OR Today Live surprise pack to the attendee that can tell me the answer to the following trivia question. Today's sponsor, Surgical Directions, is headquartered in Chicago. In what year did Chicago become the first city in the US to establish a blood bank? Answer now using the questions feature on dashboard. While you're answering, just a reminder to save the date for our 7th annual OR Today Live conference, which will be taking place August the 16th to the 18th next year at the Omni Interlochen Hotel in Denver, Colorado. Join us to discover new opportunities, broaden your knowledge, and exchange ideas. For more information, visit ortodaylive.com. Okay, and let's see who the winner of our OR Today surprise package is, and it is Susie Wharton. Congratulations, Susie. Of course, the correct answer is 1937. OR Today would like to thank our sponsor, Surgical Directions. Surgical Directions is a healthcare consulting firm comprised of clinical and business professionals who work side by side with clients to achieve the greatest impact possible. They specialize in healthcare provider strategy, operating room transformations, supply chain management, central sterile processing, and much more. They also provide interim staffing solutions for key OR roles, from OR directors and managers to anesthesiologists. For more information, visit surgicaldirections.com. Okay, and our presenters today from Surgical Directions are Dr. Tom Blasco, Medical Director, and Lee Hedman, Executive Vice President. Lee, you may begin whenever you're ready.
Thank you for the introduction. Good afternoon, everybody. Today we're going to take some time to talk about how we form a positive collaborative culture within the OR. And part of what we'll do is use surgical turnover time as a measure of meaningful improvement to change the culture.
A moment, we have a little technical difficulty here, and we're going to get the slide advanced momentarily here.
My name is Lee Hedman, and I've been with Surgical Directions since we started about 20 years ago. My career has been spent in healthcare from a business perspective, both on the hospital side as well as practice management. A lot of the work I did in practice management was with anesthesiologists, and when we would work through some of the things that were going on within their group, a lot of things were out of their control because of the inefficiencies in the operating room and the thought that they were just there to administer anesthesia and not be part of the solution for the ORs. One of the things that we've done is look through a lens of lean daily management to see what's going on in the operating room, and really to build a governance structure so that everybody starts to work together. As most of you know who are on the phone and very involved in the operating room on a daily basis, the operating rooms are really struggling. The hospital's profits have dropped below 1.5%, and part of that is because of all of the changes in healthcare. As we all know, being patients ourselves, payers and patients are now leading the change on how they get their health care. They have a demand for where they want to go, how they want to shop for their health care, and the days of just knowing a surgeon or a hospital because somebody else went there doesn't have any meaning anymore, because they can shop and look at results and the care that was taken with other people at certain facilities or by certain surgeons. The hospitals unfortunately continue to lose patients because a lot of the volume is moving to ASCs, and ASCs are an easier way for many patients. I can talk about my experience with shoulder surgery. Dr. Blasco actually recommended a surgeon that I would have never known about, And I went a 45-minute drive to my house to go to the ASC because I knew that I would get the results that I needed. It was quick, it was easy, they catered to the patient. And it was a lot different from going to a hospital setting where you have to navigate the hallways and, have long waits and things like that. So for the patients that are really shopping around, there are some advantages to what they're looking for. And then along with trying to develop more and more what the operating rooms and the clinical people can provide, we're looking to improve efficiency, both with the surgical home, advanced recovery from anesthesia, but all of those are still in their infancy, and we're still working on that. Unfortunately, most hospitals, you can see by the photos here that we have, the operating room culture has resisted to change for a long time now. We have the traditional where the surgeon and the anesthesiologist and the nurse are at the patient's side, but what goes on beyond that is pretty much traditional and not working in a collaborative environment. So one of the things that we question clients with when we go in is what is culture and what is the heart of the hospital's problems. So we really have to go in and look at not only the values, the goals of the hospital, but the attitudes of what's going on between all of the different physicians, nurses, administrators, anesthesiologists, and really look at what comes first. Is it process change or is it culture change? The hospital culture is very hard to change. And part of the reasons for that is physicians aren't taught to be team players, and they're also not taught to be a part of the solution or to work with hospital leadership. Their training does not support a collaborative team approach. I mean, they're taught to do the best that they can clinically and to do no harm, and we appreciate that. But today's world, we really want them to come to the table and also be part of how we form a better culture. We all get along as colleagues, and we do the best that we can do for our patient and their outcomes. We really want them to be part of the hospital solution and what the hospital is there to provide. And this also includes employed physicians. As most of you know, a lot of physicians are employed today, and that's a real hard change from where they come from, where they ran their own group practices or their own practice and were independent, and now they're being asked to work in more of a group function. So traditional leadership and management models are problematic, and we all have to take that on to work together to figure out what works for our particular hospital. We all have best practices that we try to follow and guide our decisions when it comes to patient management, but there's variations in the process. So if we look at a lot of the different measures that are out there, we're finding that if everybody isn't working towards the same goal within the operating room, that chances are there could be mistakes, there could be errors, and we don't want that. We want to make sure that we have process in place and that 9 times out of 10 we're following that process. What we do find in hospitals, and I'm sure that you've seen it in your own or other places that you've worked, is that there's silos. So there's physicians, both surgeons and anesthesiologists, there's nurses and CRNAs, and there's administration, and everybody wants what they want. And what we have to do is look at what's causing that. It's not just the surgeon that causes the problem in the OR, it's all the other people that work and should be working as a team. So basically, what we hear from surgeons all the time is they want better turnovers. They could go to an ASC and things would be a lot faster and they would get through their day a lot quicker and be home for dinner. So what can we do to improve the turnovers? And that takes a team approach. In anesthesia, they know that they need to be in there first thing in the morning and get the patients ready for surgery, but they also know that they want to go home. A lot of them have to be on call, they have to come back for emergencies, and they too would like better turnovers, but they don't have much to say about it. Nursing, on the other hand, they have things that they need to do early in the morning, but then we always have the fire drill, as we're told, at 3 o'clock in the afternoon, where cases are running over. They wish things could improve as well so that they could have more of a work-life balance. But when they do try to improve things, they feel like that just gets them another case, which just keeps them there at work longer. And then administration wants the rooms running 24 hours a day, all of the rooms starting at the same time in the morning. They want their utilization very high, and they don't want any complaints from the surgeon. They do believe that the surgeons are the customer. If they're not happy, they're not going to bring their cases to the hospital. So we really have to break down all of these different silos and wants and needs and see what we can do to bring it all together and to work as an organization to have a better day. So if you look at these pictures that I believe Dr. Blasco took some years ago, you can see that, one, the nurse is doing all of the work, and then on the other side, it's more of a collaborative approach. It's more of a parallel processing where everybody has a job to do so that they can get the patient out of the room while they're starting to clean up the room to bring the next patient in to improve the turnover. So again, the illustration is really about collaboration, parallel processing. If you see the picture on the right, there's numbers 1, 2, 3, 4, 5. Everybody has a job to do. So what Surgical Directions has done over the years is really built a best practice where we can really help all those different aspects of the OR. This one in particular is looking at turnover time and how we can develop that collaborative approach. And part of what we need to look at, as we talked, is leadership and governance. We need to make sure that everybody feels that they're leading the way and that they're all working together. We need to look at management and share what our frustrations or challenges are, and then sit down as a team and try to work through them. Try to look at a lean methodology to say, well, how can we do this better?
Hi everyone, we seem to be experiencing some audio problems at the moment. If you can just bear with us for a couple of seconds while our presenters try to reconnect. Thank you. I will keep you updated.
Hello, are you there? Hello?
Yes, we can hear you.
Okay, so we had internet problems within our building, and so our Polycon disconnected us. So we're going to be on a phone. Can you hear us well?
Yes, I can hear you. I'm sure the attendees will tell me if we can't hear you. So
All right,
carry on.
Despite these technical difficulties, we are going to move on. And my name is Tom Blasco, and I am an anesthesiologist and an intensivist that spent 40 years in the operating room, believe it or not. 22 years ago, we founded Surgical Directions. And since then, we've been in over 400 hospitals, or almost 400 hospitals, right, Lee? Yes. And these are not just simple meet and greets. These are implementations that require anywhere from 4 to 6 months of interaction with the entire operating room to bring about a significant transformation. So over the years, we've learned a lot of things. We've made a lot of mistakes. We've learned an awful lot. And number one, if you take away anything from this meeting, I want you to take away 2 things. First, the turnover time is the best indicator of whether your operating room is improving its processes and its culture. If you can reduce turnover time, you've made substantial improvement in your operating room and your culture. The second thing is that you need to have a new leadership model. And I've got on this slide, it's called the SFCC, a new kind of governance. And basically, it is a leadership model that includes the 4 different competing agendas: surgical leadership, nursing leadership, anesthesia leadership, and senior hospital leadership. A couple of key points here. First, this has to be an administration-sponsored committee. It's not a medical staff committee. The traditional hospital has a very sleepy surgery committee with a few surgeons that show up and they kind of talk about things and nothing really happens. But this is an operational leadership committee. And I want you to look at this slide. This is an actual SFCC, or Surgical Service Executive Committee, from a hospital in Southeast Florida. We worked on this hospital about 12 years ago, and this committee is still in operation. But I want you to look at a few characteristics. Number one, the CEO of the hospital regularly attends the committee. It has the representatives from all 4 groups: surgeons, anesthesia, nursing. But look at the number of surgeons. We structure our SFCC so that more than half, usually more than half the group are surgeons, and they represent the various specialties and the various kind of specialties, both employed and private. Also of importance, the committee is chaired usually by a surgeon, and usually there's a co-medical director and anesthesiologist. We'll talk about that in a few moments. So we're going through this relatively quickly, but the SFCC basically empowers frontline operation and process improvement. I'll give you a story. About 25 years ago, I left Northwestern. I thought I was really smart, and I was hired on in this new hospital, Lutheran General, big place, as a associate chair and director of operations. My first week there, on a Saturday morning, a neurosurgeon walks in and says, "I have an emergency carpal tunnel." Now, I don't know I think most of you on the phone probably are clinician or clinically related, but there's no such thing usually as an emergency carpal tunnel. But every Saturday morning, this particular surgeon would come in, schedule an emergency carpal tunnel, bump all the Saturday morning cases, and then get on the golf course by 9 o'clock. So in my infinite wisdom and my naivete, I basically confronted the surgeon. I said, "You can't do this. This is not right. You're abusing your privilege as a surgeon here." He goes, "Just a moment." A few minutes later, I got a call from the CEO of the hospital, and he said, "You leave this surgeon alone. Don't harass him. He's bringing in a lot of money, and he's really helping the bottom line of this hospital." I learned at that particular point in time I would never, ever, as a frontline manager and working with the nurses, ever put myself in a position where I didn't have sponsorship, authority, and backup for intervention of this kind of stuff. So that kind of stuff goes on all the time in many hospitals. So the SFCC starts to break down a lot of these silos. The first thing is that these issues are discussed collaboratively between all 4 groups. I'm going to ask a rhetorical question on the phone. Of the 4 groups, surgeons, anesthesia, nursing, and administration, who would learn the most with collaborative interaction over problem solving with the SFCC? I'll tell you the answer, of course. It's the administration. So physicians in particular start to take ownership of problems and operations. They start to hold their peers accountable. As soon as we set up an SFCC within my hospital, this particular surgeon's shenanigans that occurred every Saturday morning stopped almost immediately. And he did not leave the hospital or take his cases out. He just basically realized he now had his peers looking over his shoulder, and he couldn't do this kind of stuff. The other thing that's important about the SFCC number, and this is really important, is you have very strong and accurate analytics that drive decision making. That includes utilization, productivity, quality metrics, turnover time, first case on time starts. So we got the new leadership body that's now supporting frontline management. Now let's get into frontline management. Are there differences that we suggest? Yes. The classic operating room, like you see on this magnetic strip board on the left, I don't know what, I would say at least half the hospitals we're still in, Lee, and I'm talking to Lee Hedman right now, still have magnetic strip boards, and they have these multi-million-dollar electronic healthcare record-keeping systems. But that's how typically operating rooms are run. It's usually a last-minute affair. You're typically going to see surgeons and their offices adding on elective and semi-elective cases right up until the last moment of surgery and the day of surgery, just a few hours before surgery. And the question I have for you on the line is, why do surgeons in their offices schedule in many, many hospitals, I would say more than 80%, why do they do that? And the answer, of course, is because they can, because there's no accountability, there's no authority basically trying to bring some structure to this chaotic last-minute approach to patient care within an operating room. This is one of the reasons why hospital operating rooms are not as efficient, productive, and as high quality as they could be. We strongly recommend a much more proactive, collaborative schedule management system that replaces the traditional operating room management system. We also strongly recommend that both nursing and anesthesia step up to the plate. In many operating rooms, either the nurse, the nurse manager, directors and managers, and/or the anesthesiologist work to kind of run the operating room. The board runners for anesthesia, the nursing managers they have to work collaboratively together. They have to assist one another in basically running and managing the operating room. That takes some coaching, and that takes sometimes anesthesia groups, and I am an anesthesiologist, will kind of marginalize themselves and kind of hide in the woodwork and not take ownership. The better hospitals have a joint leadership model. The most important part of the new management system to start to deal with the need for cultural transformation is the daily huddle. The daily huddle, we discovered this many years ago back in Rapid City, North Dakota. A surgeon suggested we start looking at this. It's pretty obvious, but a surgeon suggested that, and I'll give his name, Dave Drawbeck, he was a great surgeon, suggested that we start looking at the schedule 3 and 4 days in advance with everybody involved with schedule management. That includes operating rooms, scheduling, pre-admission testing, sterile processing, anesthesia department, anything related to getting the patient into the operating room on time and prepared for surgery. This has been an incredible mainstay, successful mainstay for us over the years. And we recommend that you look at the schedule at least 3 days out, go through the entire schedule, look for issues that will surface, whether it's equipment issues, the incompatibility or the lack of C-arms, or whether it's patient preparation issues. And you have to work very closely with the offices and maybe change the order of the case. For example, let's say if you have a nursing home patient, maybe that nursing home patient shouldn't be the first case of the day. Maybe it should come later in the day when they have time to get the patient from the nursing home to the hospital and prepared for surgery. So we've talked about leadership. We've talked about frontline management, which includes anesthesia and nursing working together, and then a daily huddle that starts to eliminate a lot of the delays, cancellations, and all the other issues related to a poorly prepared patient. Now, finally, we get to the front lines. So we've talked about leadership, now management, now process. And we're only going to talk about one process in one area today, and that is, because we look at a lot of different stuff when we go in, but that's turnover time. As we said before, turnover time, when you can improve it, basically will tell the story that your entire operating room process and culture is changing. So what is turnover time? There's really two types of turnover time. There's wheels out to wheels in, which is traditionally what most people measure. But there's also the case finish to cut time and next case start, and both need to be measured. Some of these benchmarks here are internal benchmarks for surgical directions. We believe that most hospital operating rooms can have anywhere from a 15 to 25 minute wheels out to wheels in, and that a dressing on to subsequent case cut time should be no more than 60 minutes. Okay, so I'm going to put this whole slide together for you. And what we're seeing here, we're seeing the two turnover times. We're seeing the surgeon turnover time, which is basically from the time the dressing's on to the time the cut time. I mean, we've been in hospitals where they're very proud of having a 28-minute turnover time, but they have 118-minute surgeon gloves off time. So when you look at turnover time, you have to look at both wheels out to wheels in as well as surgeon turnover time. Some of the most common issues related to why turnovers are so, I mean, anybody who's worked in the operating room has seen these issues surface. These are very common sense things. First of all, you got a large variation in staff efficiency, whether it's anesthesia and or nursing. You got your superstars that work very hard Surgeons love to work with them. The room moves quickly. It's efficiency. Then you got your clunkers. These are people that are part of the culture of apathy. They resist change, and when you challenge them on improving turnover times, they will complain of inappropriate production pressure or that you're putting the patient at risk. Many op rooms, and I'd say most op rooms, have a very poor surgeon access system that creates gaps, stacking of cases at night, and the nursing department in particular, anesthesia department secondarily, are faced with either unpaid time off because rooms are being closed or excessive turnover time. Ineffective management. I would say a good percentage of our clients have ineffective management for a variety of reasons. But basically, if you can't develop a culture of accountability within your frontline staff, you're going to have poor turnovers. Surgeons and anesthesia get lost. Why do surgeons and anesthesiologists get lost, or CRNAs get lost? Is because they expect long turnover times. Case cards incomplete. And then there's the classic serial processing versus parallel processing. The classic example of this is the tech yells out to the nurse or the anesthesiologist, "Don't transfer the patient until my counts are complete." Again, that's a strong indicator of a poorly choreographed turnover. And then finally, there are patient delays. It's a complex slide, but what it does represent is the multiple areas that have to be addressed from a leadership, operations, and infrastructure perspective to get a good turnover. That's why if you can improve your turnover times, you have an operating room whose process is much improved. So it's anything from the daily huddle, process optimization, anesthesia, staff engagement, governance. It's a whole bunch of different areas that have to be addressed. And we'll show you a couple of ways how we do this. Okay, so improving turnover time is it's a transformation thing. And there's tremendous amounts of business literature and science that basically list ways that the steps that are needed in bringing about change. The first one, of course, is building a burning platform, actually establishing the sense of urgency that you're really going to have to change. Of the 60 million procedures done in the United States in the surgeon's office, in the ASC, in the hospital, only 10 million remain in the hospital overnight. That's less than 20%. If that doesn't create a burning platform that your hospital to survive is going to have to really start competing with the ASC and the surgeon's office for patient efficiency, productivity, and quality of care, I don't think anything else is going to help. Establish a very defined vision. What do we want? We want to have reduced turnover times. We'll talk about what's a reasonable expectation. Build an effective management and with including both physicians and staff. The biggest problem we've learned over the years is that we have to, although we have a small group actually starting to construct the new turnover times and build the new future state, this has to be communicated continuously to the staff. You're going to empower broad-based improvement, but you have to start with pilots. Trying to improve turnover times at one time throughout the entire operating room is nearly impossible. You start with pilots, and you tweak issues that surface. You try to achieve short-term wins, and you reward success, which is somewhat difficult to do within an operating room, but we have some suggestions. You consolidate gains, and then finally you make the cultural change permanent and anchor improvements. But this is the 8-step process that almost any business textbook will go through. So, putting this 8-step process into reality, we strongly believe in the Multidisciplinary Performance Improvement Team, or PIT. In this hospital is in upstate New York, and basically everybody involved with turnover is on this group, whether it's the people that the environmental people, or it's the nurses or techs, or it's anesthesia, or it's nursing leadership, or pre-admission testing, or the pre-op holding area. Everybody that's related, they have representatives for all the different groups that begin to define what you're currently at, your baseline metrics, and what your future state's going to be. And then you start to develop an ideal process. It takes a pilot, as we said before, a lot of tweaking as the pilot as you begin to find issues and problems that have to be addressed. And then you start rolling out to the rest of the operating room, and you start mentoring and coaching, and then hold people accountable. You will find, as a general rule of thumb, that 80% of, initially 20% of people in your operating room will be very excited about this, about improving turnover times. The rest, 80%, will somewhat skeptical. Of that 80%, about 60% will eventually embrace the change, but 10 to 20% will never embrace the change, and then you have to make decisions. So this is an actual hospital. This is on the northeast, in the northeast, and we started the intervention in in November of 2018. Now, this is about a 12 operating room, very busy, tertiary care. And this is these turnover times. This is wheels out to wheels in. Is very average for most hospitals in the United States. Anywhere from 32 to 40 minutes is an average turnover time for most. That's wheels out to wheels in. Not to mention the hour and a half or gloves off time. With our intervention, we began to see significant change. And by the time May came around, we actually reduced turnover time by about 8 minutes. It's almost 30%. And right now, the turnover times are about 25 minutes at last check. So they were able to reduce their turnover time close to 40%, which indicated a massive change in their process. We'll give you some of the reasons why. The first is you have to be patient. It takes literally months for people to internalize change. Don't expect to roll out, have the concept built and to suddenly roll it out the next day and it's going to work. It takes a while for people to catch on. It takes a lot of leadership and management and holding people accountable. You have to choreograph each person's role and hold them accountable. We like the concept of swim lanes, where each person is given a defined set of roles and expectations. It does not mean they have to keep it every single time, but they have a general idea of what their responsibilities are and when they should do them. Physician participation is the key. And I'll give you an idea. In this hospital we just talked about, with the improved turnover time, the physician on the SFCC, an anesthesiologist, basically said, why don't we, as anesthesia, working with nurses, establish a return time to the operating room? In other words, before they leave the room, somebody takes the responsibility saying, okay, it's noon. I want the next patient back in the room no later than 12:25. In other words, you're establishing expectations. And that's to be specific for turnover times for each case, and especially type of case. For example, you don't expect a back-to-back robots to have a turnover time of 15 minutes, but you do expect endoscopy procedures and/or simple cataracts to have turnover times of less than 10 minutes or less. Display daily progress. We'll talk about that in a few minutes. We got a great example of that, and reward success whenever possible. Okay, so we're going to end a little bit early with a great example of taking all the leadership, the management, and the process improvement to the next higher level in a best practice operating room. This operating room is in the southeast, and it's in North Carolina. It's a very busy operating room. It has 18 operating rooms, lots of tertiary care cases, and they came to us to help them start to build in a senior leadership model. They called theirs the Perioperative Executive Committee, the PEC. They developed the daily huddle. They developed better frontline management, and they started looking very carefully at turnover times as an indicator of changing operating room culture and process. They took 4 data points off their EPIC EHR, and the 4 data points were wheels in, cut time, dressing on, and wheels out. And so they extract, it's relatively easy to do. You extract these 4 data points, and they actually put them into they wanted to visualize them and put them in a very easily visualized graphics to help people real time understand how they're doing. And you can see on this slide, there's both green and yellow. There's also blue, but that means the rooms are not being used. But the green means the patients in the operating room. The yellow indicates the patients in the rooms in the turnover time period. They also, you can look in the fine points, but they're also you can actually see here it's pre-cut or post dressing on, so that they have warnings. So if you break this down, for the top example with Bennett, Point, and Zeman, you can see this operating room is running pretty well. It starts on time. The turnover times are relatively fast, 23 and 25 minutes. And they're getting 3 cases in by a little after, by 10 o'clock. On the other hand, in the Hall Tinsley room, the second case, the case starts late. It's indicated in red. And Hall finishes up, but Tinsley can't be found, and the turnover time is delayed. Put this into a whole day schedule. This is much more of a complicated slide, and it goes from left to right. Left being the start of the day, about 7 o'clock, and it goes through about 10:15. And you can see that 5 cases start late by the red start time. So of the 18 rooms with 1 open room, you have 5 late starts, and that means your first case on time start rate is 64.29%. They're also in real time managing room utilization, and they're looking at room utilization. They're also looking at real time turnover time. And these 18 rooms, by 10 o'clock that morning, their turnover times were averaging 27 minutes. As we said before, the typical operating room in the United States, a busy operating room, averages about anywhere from 32 to 38 minutes for wheels out to wheels in. Not only that, since we had this slide, they've actually reduced their turnover time to around 20 minutes. They were picked in the North Carolina area as having the most efficient, high-quality operating room in North Carolina. So it's real-time visualization of what's going on, and we think it's very important. And it can even be done with Epic and Cerner. You can ask your IT people to start developing some of these visual graphics. So with all this information, and you can see in the upper right, these teams do their daily huddle with all this information in mind and their future schedules in mind, and they're using it to really produce not only fast turnovers, but a highly efficient operating room. And people are being rewarded monetarily, both the nursing staff and anesthesia staff, for the cost savings that the hospital is actually receiving from this massively improved efficiency, productivity, and quality. It's been demonstrated by a lot of statistics, and I'm not going to go through this in detail, but the hospital is one of the most productive hospitals, as we said before, in North Carolina. So as a takeaway from today's discussion, I want you to remember one thing: your turnover times reflect your culture. It's very important that to really document and improve the culture, you're going to have to document and improve turnover time. The intervention that has to occur at 3 levels: leadership, the traditional approach with a nursing director running the operating rooms with very little support, lots of responsibility, very little support. It's not effective. And your competition doesn't have this model. If you look at a typical ASC, they have a surgical service executive committee run by surgeons. They have anesthesia, nursing, and business managers at these monthly or quarterly steering committees. Management has to be much more proactive, and the daily huddle, which is looking at the schedule proactively, is a tool that we have found to be incredibly important in improving your operating room's productivity and efficiency. And then there's the whole concept of how do you change a process, and you have to go through a step-by-step approach using a steering group called a performance improvement team that's multidisciplinary, that breaks down process, puts it back together. You have defined goals of what you want to do, and you're constantly measuring your process and your improvement. And then it's only then that you do a pilot, and only then that you begin to roll it out to the rest of the opera, holding people accountable. I know this is a lot of information over a short period of time, but I hope you've gained something from this. I guess we're ready now for any questions you may have.
Great, thank you so much, Tom and Lee. We've got a couple of questions here. The first one is, what are some strategies you have used to reduce long turnover times between any cases?
Well, that's the $64 million question. And the strategies are, first of all, you have to first of all establish where you're at, and you have to establish your benchmark. As I said before, if you're not in the 20s in terms of your turnover time, you really need to address the issue. The strategy includes, you're not going to improve turnover time until you address this from multi-level intervention. As I said before, you can't just walk into an anesthesia departmental meeting or a nursing meeting and say we're going to improve turnover times. I want everybody to start working faster. It starts with leadership. I'm going to say this again. It's kind of redundant. Leadership, management, and process. All three things have to be brought into place, and you have to have physicians as a major part of any improvement effort that includes turnover times. Why do surgeons come late in the morning? Because they can, and because they expect to start late. So one of the adages that Surgical Directions has is we are not going to expect surgeons to come on time unless we have our house fixed, that both anesthesia and the nursing department have their rooms ready to go at an appropriate time then you can start holding the surgeons accountable with specific expectations. So it's a very broad answer to a very broad question, but hopefully that answers some of it.
And I think one of the starting points is maybe to do a pilot program, say for instance with urology, whatever cases are going, and take a look at their turnovers and actually time them out, kind of visually watch who goes in and out and how that is done, and then take it to a small group of people to actually look at it and decipher what they can do to change it. So don't try to bite off every room and every specialty. Take it step by step.
You know, and some of our clients, they do just that. It's very interesting when they actually photograph or actually video an average turnover. Sometimes, and they do it kind of on the slide because you got to avoid the Westinghouse effect. I still remember when Lee and I many years ago were photographing a turnover, and there was 14 people that suddenly showed up in the room, and they were fighting out over who was going to take the garbage out of the room. Right. So we learned a lesson long ago. It's got to be done kind of secretly, but they also video the new expected turnover process, which is very powerful once they all figure out how they want to do it to make it better and start to show the video, and it does work.
Okay. Another question here is, how have your projects helped improve teamwork and work-life balance in ORs?
Okay, good question. Work-life balance, it generally suffers when an operating room is poorly managed. What happens this is not just nursing, it's anesthesia also. What happens in a poorly managed operating room at 2:30 or 3 o'clock when you have a poor surgeon access system and surgeons are adding on cases and they're getting stacked at night? Somebody walks into your room and says, could you stay for a couple, 3 hours? We got these add-ons. Or could you go home because we don't have any cases for you? It's Friday and we're going to send you home without pay. So this is another good question. To really improve the culture within an operating room, you really have to develop a surgeon access system where the predictability of staffing is much improved. In other words, you try to engineer this is a whole art unto itself and a whole other lecture, but you try to introduce a surgeon access system where the variation from day to day, hour to hour is engineered out of the schedule as much as you possibly can. Typically in our efforts and our successful efforts, we will reduce after hour cases or daytime cases by at least 50%, sometimes more. One hospital in another hospital in North Carolina, they had this problem with lots of weekend stuff, lots of night stuff, and we switched the operating room from an 8-hour day, these were 12 operating rooms, to a 10-hour day. The stacking went completely away. The nursing and anesthesia department knew that they would work a 10-hour day and the chances were 95% they would be going home. And the weekend cases went away because there was much more capacity at the right time. Nobody wants to stay late, and very few people want to work in the weekends. There's always a nut surgeon that likes to do a major back procedure on Sunday morning at 12 level, but those are exceptions rather than the rule.
And I think one of the things that Dr. Blasco brought up early on is that you really have to, partner as a group in your room for that day. Kind of look at the clock at 7 o'clock in the morning and say, okay, we have X amount of cases. Let's make this happen and let's all get out of here by whatever time, 4:30 or whatever, and work together to make that happen. Again, it's that team approach versus individuals, and then everybody wins.
What's the classic refrain from a nursing anesthesia department when they say, that we want you to work harder, and they say, what's my reward? I get another case. So it's how you develop a staffing model that avoids that complaint.
Other questions?
No, we haven't actually got any more questions at the moment, so we will wrap it up now. So thank you, Tom and Lee, for a great and informative webinar, and thank you obviously again to our sponsor, Surgical Directions. Just another quick reminder that the post-webinar survey and certificate process is now automated, so the survey link will be included in the follow-up email, which will you receive in about an hour's time. If you've completed the survey, you'll be able to download your certificate immediately, and one lucky attendee will win an Amazon gift card for completing the survey. If you have any questions, please contact us at webinar@mdpublishing.com. And for more information on our upcoming OR Today webinars, please visit our website, ortoday.com. So once again, thank you to everybody for attending today, and to you, Tom and Lee. Hope everybody has a great Thanksgiving, and we will see you next time.